All pelvic pain diagnoses are not created equally. Some of our chronic pelvic pain diagnoses actually point to a specific finding, to a specific pathology or mechanism of disease, a thing that's causing the symptoms. And a whole bunch more of these diagnoses are just labels. Unfortunately, they do not tell us what is wrong. They're given without any specific tests that show that you have them. The tests are basically showing that you don't have anything else, and then you're given this label that most of the time is simply like body part plus pain, like physical location and then a Greek or Latin word for pain. And I'm sorry, but that to me is not like a real diagnosis. So vulvodynia, dynia is Greek for pain. Pudendal, as in the pudendal nerve. Neuralgia, neuro is nerve, algia is pain. It's just pain coming from the pudendal nerve. Clitorodynia, clitoris is a location, dynia is Greek for pain. Vestibulodynia does get a little more specific than vulvodynia. The vestibule is a specific type of tissue and a specific location in the vulva, but it's just pain there. It's not saying whether it's caused by autoimmune disease, virus, fungus, bacteria, congenital condition, allergic reaction, a problem with your veins, autoimmune, did I already say autoimmune? Autoimmune skin condition. And despite the name, interstitial cystitis is unfortunately in practice another one of these location pain diagnoses. It's a diagnosis of exclusion. It's sometimes a garbage pail diagnosis. Like if you look up wastebasket diagnosis on Wikipedia, chronic pain conditions, including interstitial cystitis, are examples of that. The reason IC is kind of a tricky one is because it could have a physical finding. Cyst is the bladder, itis is inflammation, interstitial is a location, it's the bladder lining, so it's saying that you should have some inflammation of the bladder lining. However, in practice, this diagnosis has been given to patients in the absence of findings of things like UTIs and cancer. It simply hasn't been given out exclusively to patients with positive findings in their cystoscopies, which is when you look inside the bladder with a camera. Which is why, for I think at least as long as I've been around with it, which is almost 20 years now, it's been called painful bladder syndrome. So a syndrome medically is just a collection of signs and symptoms. In this case, the sign and symptom is bladder frequency, urgency, and pain. Those are all subjective experiences of the patient. They're not something a doctor is seeing on a test or on a imaging. So the reason this is important is because today I saw someone say they were really confused and frustrated because their doctor said, like, you don't have interstitial cystitis. Now, maybe something's changed since I was last really in that urology IC world. I still have interstitial cystitis because I have bladder pain and symptoms, but I don't seek medical care for those symptoms, and I now have another problem, irritation in my pudendal nerve since a surgery to an area innervated by the nerve that has that nerve innervates the bladder, and I think that's also worsening my symptoms. But maybe something's changed, and maybe now they are only giving interstitial cystitis diagnoses to patients that have positive cystoscopies, so some sort of visible ulcers or inflammation in the inside of their bladder. But as far as I can see from being on social media the last few years, looking in medical journal articles, going on web pages for the societies devoted to the study of these things, I haven't heard about that change. So maybe just correct me if I'm wrong. So if it hasn't changed, then a doctor really can't tell a patient that you don't have painful bladder syndrome. If a patient has a painful bladder and you haven't given them any explanation, you haven't proven that that's coming from another cause, how can you tell them that they don't have it, because it is just symptoms. You're just describing the body part and that it hurts. So that's what we all need to understand. This reality, it can be good and bad, because if you have one of these location pain diagnoses, vulvodynia, pudendal neuralgia, painful bladder syndrome, clitorodynia, that is just saying that you have pain there, and that a very non-standardized list of tests that could vary from place to place has not detected another cause for your pain yet, and it means that there could be another discoverable cause of your pain. that you could get treated for and get better from. So that's the good news. The bad news is that a lot of people I see a lot of patients and maybe even doctors sort of like not understanding this and sort of thinking that if we all have vulvodynia diagnosis, we all have pudendal neuralgia diagnoses, we all have IC diagnoses, that we're all suffering from the same disease. And that is super not true. Again, these are just labels of body part location / feels pain there. So it's like saying stomach ache. It's like going to the doctor saying my stomach hurts, and they say, well, I don't see a tumor and I did a test for bacteria. I don't see a pathogen, and then I can't think of anything else, so I'm diagnosing you with stomach ache. So before and after that doctor diagnosed you with stomach ache, you still had stomach ache. Same thing with a headache. Like you can go in with head pain and the doctor can eyeball you and maybe give you a x-ray. Because, part of the problem in our society with these pelvic pain diagnoses is that there's a lot of testing that doesn't happen to the average patient, that isn't accessible. In the case of pelvic pain, it seems most of us immediately at the get-go get checked for STDs and UTIs, and that's it. Maybe we get an ultrasound to look for cysts or tumors, and maybe we get an MRI, and when those things are negative, we're told we have a pain syndrome. But when you live in this world a little bit longer, and you have, like me, have had like a weird, insane, many different kinds of problems, you realize that those things, an STD test and a UTI test, that's not the extent of all possible things that can go wrong in someone's pelvis, or, cancer. There's all kinds of other illnesses and diseases that all require specific testing to rule out. For example, endometriosis can only be really ruled out with a laparoscopy, which is when they take a camera and look inside and look for it. And that's an example of like what I call a real diagnosis. It's a finding. It's something they found in testing that explains your symptoms. That's something you can actually have. Whereas when people say like, I have vulvodynia, I have IC, I don't know, it's almost like saying that you have a cloud. Like we can see a cloud, we can label the cloud, but we can never grab the cloud. And that's sort of a super hippie, weird way to say what I'm trying to say, but that's what I'm thinking of right now. So like pelvic floor muscle dysfunction, that's a real finding. That's something that can cause vulvodynia and can cause pudendal neuralgia. However, tight muscles, chronically tightened pelvic floor muscles, or any kind of pelvic floor muscle dysfunction is not the only thing in existence that can cause bladder pain, vulvar pain, pelvic pain. And on top of that, the other things that can cause some of these pains, like let's say hormonal atrophy can cause vestibulodynia or insufficient hormones, that would be a root cause of vulvodynia. But that living with that could also cause you to chronically tighten your pelvic floor muscles because they're always in pain, especially when you're doing things. And so then you would have pelvic floor muscle dysfunction as a consequence. But maybe you don't have insufficient hormones and you are a professional ballerina or a weightlifter and you are constantly tightening your pelvic floor for what you're doing a lot of, or you're really, really stressed out all the time and you unconsciously clench your pelvic floor, then you could squeeze and irritate your pudendal nerve and have pudendal neuralgia, and then the treatment would be learning to relax your pelvic floor muscles. But you could have pudendal neuralgia from scar tissue from giving birth or a traumatic surgery or an injury that damaged your actual nerves, and it could have nothing to do with your pelvic floor. So the reason it's important to understand that these are just labels is because many things can cause pain. Many things can cause a headache. Many things can cause a stomach ache, like a super duper number of things. And like the same number of things that can cause a headache and a stomach ache, why would the entire pelvic region be any different? You can have pathogenic bacteria causing stomach problems. You can have organ failure causing stomach problems. You can have, tightness and stress causing stomach digestive problems. You can have appendicitis causing stomach problems. You can have Crohn's disease, ulcerative colitis. You can have celiac disease and autoimmune disease. So if we didn't have tests to sort of differentiate those different causes that I just mentioned, which is the case for a lot of pelvic pain, especially female pelvic pain, we don't have tests to differentiate them that are accessible to most patients. You walk and you say, I have a stomach ache, and then the doctor just says, I can't find anything wrong, so you have a stomach ache. And that's what a lot of us with vulvodynia are doing. We're walking around like that. And keep in mind that with something as universal as like stomach aches, the cause of peptic ulcers being the H. pylori bacteria was only discovered relatively recently. And like the protocol for testing for that is only a recent development.